Welcome back. We're talking with hematologist oncologist Dr. Anup Lal. We're talking about anemia. Okay, let's kind of talk a little bit more about diagnosis. You said that CBC was a first step.
So from the CBC, we go to the history and physical. A lot of times, for example, if somebody is giving us a history of bleeding in their bowel movements, then that'll give us a good clue about what the anemia is from. If someone has a family history of sickle cell or thalassemia, that give us another clue. If somebody has a big spleen, then that could indicate primary bone marrow or blood problems. So a history and physical exam is the next important step. Then we order additional labs. For example, if we suspect iron deficiency, we will check iron levels, vitamin levels. We check for abnormal proteins that could indicate certain kinds of bone marrow conditions. If we suspect hemolysis, then we order labs tailored to that. So there's a whole panel of labs that you can order based on your CBC and your history and physical and your clinical impression to rule out the different types of anemia. From there on, you can go on to more complex procedures. For example, if you suspect somebody is losing blood in their bowel movements, they may need a colonoscopy or endoscopy to find the source. Another example would be if we suspect a primary bone marrow problem, then they may need a bone marrow aspiration and biopsy to look at the bone marrow directly, and that's often the diagnostic test or gold standard for certain kinds of anemia where the bone marrow is abnormal. The bone marrow is what is abnormal and not making blood properly.
And then you go on to treatment based on what you found. So let's take the main cause you said of iron deficiency anemia. How do you treat that?
So for iron deficiency anemia, the treatment is supplementation of the iron. Well, let me go back a little bit. If you have somebody with severe anemia of any kind, you have to stabilize them first. And sometimes patients who have severe anemia or severe symptomatic anemia may need a blood transfusion just to get the blood up temporarily till we can find the cause and treat the cause. So for iron deficiency, for example, if they are bleeding or bleeding out, then we need to stop the bleeding. That would be the main treatment in those situations. For the more common iron deficiency causes like chronic blood loss, we are really looking at iron supplementation, giving the patient iron back to their body in the best way possible. In addition, again, if we suspect, for example, that somebody may have an ulcer or tumor, then we need to investigate that and treat the underlying condition or underlying cause of blood loss too. But iron supplementation is something that we do very commonly. Most people know, they have taken an iron pill either as a multivitamin or as part of prenatal medications and so on. The main thing with the iron, oral iron, is that you have to take an adequate dose, and you should continue taking the iron not only till your hemoglobin is normal, but till your iron reserves or iron stores also become normal. That's a very important thing to do when treating iron deficiency. Now, in patients who have become iron deficient because they cannot absorb iron because of bowel problems, surgery, or other bowel conditions, we may have to give them iron through the IV.
How about then vitamin deficiency? What do you do there?
So similarly, most vitamin deficiencies, especially B12 deficiency, usually happens because we don't absorb B12 properly. So while you can give B12 by mouth, since the most common cause is lack of absorption, if you give them B12 by mouth, they probably won't absorb it. So usually for B12, we prefer giving patients injections, and the schedule of injections depends on the severity of the B12 deficiency. For folic acid deficiency, we usually give folic acid tablets, and folic acid deficiency actually can occur pretty commonly. The most common group is women who are pregnant, because folic acid is really used up for development of the fetus. So prenatal vitamins, folic acid is a major component of prenatal vitamins. So folic acid is usually given as a pill, B12 usually given as an injection. Iron can be given as a pill most commonly. Some situations we use IV or we call it parenteral supplementation, where we bypass the gut, where we suspect the gut's not working, and give it directly into the bloodstream.
So this treatment is really ongoing for quite a period of time depending on the cause of the anemia.
Exactly.
How about hemolytic anemia? How do you treat those, that class?
So the hemolytic anemias, where the patients have immune hemolytic anemias, where your immune system is attacking your red blood cells, the mainstay of treatment is suppression of the immune system. You want to suppress the immune system so the cells don't get attacked like it was. So one of the main ways that we treat it is steroids and IV immunoglobulin. That's the first step in treating immune hemolytic anemias. Now, in patients in whom this is a recurring problem, you put them on steroids, they respond, but you can't keep somebody on steroids for a very long period of time because it can cause a lot of side effects. So if the problem comes back when you try to take them off the steroids, then there are other ongoing immune suppressive therapies that you may have to use. In certain situations, we take the spleen out because the spleen is where the immune system, the antibodies in the immune system attack the red blood cells. They cause the red blood cells to clump together, and the spleen then destroys that clump. So basically, sometimes by taking the spleen out, you can also reduce the effect of the immune hemolysis. We usually don't do that too much anymore because we have more and more sophisticated immune suppressive therapies that we can utilize. In patients who have hemolytic anemia because of hemoglobinopathy, where they have abnormal hemoglobins like sickle cell and thalassemia, those are much more difficult to treat. I mean, there's no benefit of suppressing the immune system. Those patients are usually transfusion dependent. They usually require transfusions from time to time. People who have sickle cell anemia can get sickle cell crises where the cells shrink down, clump together and block the blood vessels, and they are treated again with oxygen and IV fluids and pain medications. Those patients who have severe thalassemia or severe sickle cell anemia, their lifespan is shortened considerably by the complications of these conditions and by the complications of iron overload due to receiving blood transfusions very frequently. So really the treatment for them is a bone marrow transplant. You essentially have to change the blood making mechanism in those patients if you can, if they're fit enough for that.
Thank you so much. You've given us a lot of really good information, really raised our awareness of the importance of understanding your hemoglobin.
Yes.
Thank you for joining us. If you have any questions about anything we've talked about, you know, you can always call us at Health Access. That's 1-800-228-1484. You know, you can always go to our website. That's mclaren.org/PHTH. And there you can watch any segment of this program. You can ask for a copy of the program. We hope you join us again next week for Today's Health. Today's Health is brought to you by McLaren Port Huron, a leader in healing and your partner in health.